Welcome to our webinar on public hospital districts in Washington State. This webinar is a project of the League of Women Voters of Washington's Civics Education Program. The League's mission is to defend democracy and empower voters. Our Civics Education Program is intended to give the public the information they need to make good decisions and to act on their own behalf as residents. Why is it important to learn about public hospital districts, which we also refer to as PhDs? Healthcare is a big part of our lives. Healthcare insurance and services can be a very large part of a family budget. And local clinics and hospitals can be the largest employers in your community. Although Washington's public hospital districts are formed by a vote of the people and partially funded by property taxes, they're not well understood. Public hospital districts can be one option to help fill gaps in communities where needed services aren't readily available and could offer choices in personal health care that may not exist today. Furthermore, in areas with a public hospital district, many residents do not realize they actually own their local clinics and hospital or other care provided by their public hospital district and are unaware of their ability to influence local health care through voter attention and action. If more people are aware of these entities, they can pursue the options that public hospital districts may allow. Through its law enabling PhDs, Washington offers its voters a way to influence this important part of their lives. And because these entities are governmental in nature and rely on local elected officials to govern them, the League of Women Voters Civic Education Program can provide this information to inform those efforts. This presentation is the first in a series of 3 modules in the Civics Education Program. In this module, you will learn what are public hospital districts and what do they do? What are some current gaps in existing healthcare that may need to be filled? How are operations of a public hospital district financed? How can voters ensure their communities have local control and choices when it comes to personal health care issues? A second module will be a slide presentation describing how the public might work effectively with the locally elected public hospital district commissioners. A third module will be a web-based toolbox explaining how the law allows the public to go about establishing a local public hospital district should they choose to do so as one solution to address gaps they may have identified in local healthcare services. From here on, we're going to refer to public hospital districts as PhDs. As part of our introduction to PhDs, we've included video clips produced by the Association of Washington Public Hospital Districts. You can learn more about the association at awphd.org. As you will see, each local PhD and its service offerings can be tailored to the specific needs of its own community.
I've lived in Forks most all my life. I'm 58 years old. I was gone 7 years to school and lived here the rest of that time. My wife and I run a bed and breakfast on the edge of town. We take care of, anybody that comes to visit, people that are working here, fishermen, people that are coming to visit the national park, and recently Twilight fans coming to see the town of Forks. Forks has a very delicate fabric, I guess, of how we exist here, both in jobs and in the services that are provided to the town. And without a hospital, we have 60 miles to go to Port Angeles or 100 miles to go south to Aberdeen. If we didn't have a hospital here, we'd be losing people.
Well, I think that's one of the important aspects of this community. Here you are in what some people would say is the middle of nowhere or a very rural area, and yet we have this world-class hospital and also hospital clinic with a lot of very qualified physicians and practitioners to care for us. So we feel quite lucky.
The great thing about a public hospital district, it's owned by the patients and citizens of this community. We're a nonprofit governmental entity that's focused on providing the best possible health care to our local community. And it's very rewarding for our medical staff and our employees because our mission is very significant to our community.
Our hospital district covers 800 square miles of northwest Kittitas County.
We are a 25-bed critical access hospital, so the only hospital in Jefferson County.
Soap Lake is a small community. It's one of the communities included in the district. We're a 42-bed facility. We do long-term care. That's our specialty.
No matter whether it's a public district hospital that's in an urban area or a suburban area such as we are, or in a rural community, each one has its differences and its special nature, but there is a common theme.
As a public district hospital, we receive taxes from our district residents, and that's the difference between being a public district hospital and not. And so roughly 5% of our revenues come from a tax base.
Those funds help us to do amazing things in our community that otherwise wouldn't exist, because there is no sound business model underneath of them to allow them to exist, and yet they very much need to exist. Senior services, grief and bereavement, the ability to have a 24-hour nurse call center.
I would think that a hospital out here, if it wasn't a public hospital, would be challenged to financially manage itself. Say a privately held hospital, I think probably what would happen is there would be some clinical coverage, but there wouldn't be the full-scale hospital that we're so blessed to have here.
Growing up, I can remember times with 105-degree fever and, mom bringing me down. And, when a mother is worried about her child, then they need a place to go to. So this is it.
The public hospital district model is basically a model that allows the local public to be involved in the leadership, provide a board and the leadership and community support to the hospital.
I'm currently the president of the Board of Commissioners. I'm a commissioner for Public Hospital District Number 2 in Clallam County.
And we've invited the general public to show up and voice their suggestions.
Our job is to make sure the policy is set, to see to it that we're running legally. We have fiduciary responsibilities of various kinds.
There's a different connection that our commissioners have compared to other organizations I've found, where they not only help govern strategy, policy, selection of the CEO, but they are representatives of the community, and it creates just an additional but very powerful connection.
We are constantly talking to our community and getting feedback from our community. One big thing is our Sequim residents, which are about 16 miles away from the hospital, really wanted some kind of urgent care walk-in clinic. So if they needed urgent care, they didn't have to come all the way to the hospital and wait in the emergency room. So a couple of years ago, we started a walk-in clinic in Sequim, and that's been very successful.
The hospital is such an essential component of our social fabric that it feels good to have something to do with it, to have some ability to control what happens.
Together with Olympic Medical Center, who is also a public hospital, we were able to join with them as well as Forks and form a coalition. With this coalition, we were able to develop an improvement in buying power as far as being part of a larger buying group and access to upgrade in our medical information technology.
District 1 and District 2 have a interlocal agreement which spells out some services that they can provide to each other.
I've been fortunate to be able to travel across the state and across the country and talk to peers in emergency medical service and see other systems for areas of this size. And what my experience has shown me is that because of the relationship that we have between Hospital District 1 and District 2, we're able to provide better services and a higher level of patient care than would otherwise be available if that partnership did not exist.
Healthcare is really local. And having a local public hospital district working with the entire community, including the other healthcare providers in the community, that's the way healthcare reform is really going to happen. Making this healthcare delivery system better isn't going to happen in DC or even Olympia. It needs to happen boots on the ground in the community, working with a variety of partners.
There's many moving parts to the Affordable Care Act, and we're hearing there's a lot of new terms and new concepts being brought forth, including accountability, the accountable care organizations and payment for performance. My conclusion about a public district hospital, in addition to the things we already talked about, it is the essence of an accountable care organization. We are an ACO even before that became a popular term.
We're totally committed to this community. That's all we do. And I think that adds a level of engagement that makes a difference for our patients. Public hospital districts are very unique. And I think in rural areas, given the economic pressures, a much larger population of poor patients and elderly patients and uninsured than urban hospitals. And I think it requires unique dedication and focus to meet a community's needs.
My mother, in the last year of her life, spent a year here at the Forks Hospital long-term care. And it was so nice for us because she was in Forks where we could visit her every day, evening, morning, whenever we wanted, instead of making a long 60-mile trip to Port Angeles. And because the hospital is under the jurisdiction of a board of directors that are elected, they're very accountable to the needs of the community, and one of those needs is the long-term care. And so I just think that she got the best care possible. I consider all of her caregivers a group of angels, and we just couldn't be more pleased. And I don't think we would have that without this facility here.
Our current healthcare system does not provide a consistent level of service to all residents. There's a great variation across our state's 39 counties and between urban and rural communities. Even with 133 hospitals in Washington state, many communities are missing critical healthcare services or find the travel time to those services creates an obstacle to needed care. The kinds of healthcare services that are available vary widely from one area to another. One of the ways that communities can get the care they need is to form a public hospital district or to ask their existing PhD to look into providing that care. This webinar will further explore the potential for existing PhDs to fill local gaps in care, and will explain how the law permits a community to create a new PhD if needed. So, what is a public hospital district? PhDs are among many types of special purpose districts authorized under Washington law. Special purpose districts are jurisdictions established by a local vote of the people within their boundaries for a specific function. In most cases, these special purpose districts also include taxing authority with voter approval. Some examples of other types of special purpose districts in Washington include transportation benefit districts, library districts, park districts, and flood control districts. In each case, the voters approved a proposition to establish the boundaries, purposes, and taxing authority to establish and fund the special district. Each type of special purpose district has its own section in state law, the Revised Code of Washington, called RCWs. PhDs are authorized by RCW Chapter 70.44. PhD boards of commissioners consist of 3, 5, or 7 nonpartisan commissioners who are elected by the voters in the district. This provides a level of public accountability not found in private, non-governmental sector healthcare providers. PhD boards are subject to all the same open meeting and public records requirements as other government entities. In odd-numbered years, voters in the district have the opportunity to elect individuals to fill any available positions on the PhD Board of Commissioners. When candidate forums for the public are held, they can include the candidates for these commission positions. And just like many local leagues monitor county council or city council meetings, league volunteers and other members of the public can monitor PhD commissioner meetings and share their observations with other interested individuals or groups. As a result of the COVID pandemic, many meetings are held virtually, and many are moving to enable hybrid attendance, so volunteers can observe from any location. Even though their names sound the same, well, almost the same, PhDs are not public health districts. Most people are already familiar with what a public health department or district is. These are established by state law also, but on a county-by-county basis. Each county legislative authority, the council or commission, is charged by state law with establishing either a county health department or a health district to assure the public's health. Although the charge to public health departments or districts is to assure the public's health, this is typically done through epidemiology and communicable disease prevention and treatment with very few direct personal health services. It often includes environmental health programs such as drinking water quality, shellfish monitoring, septic tank standards and inspections, and more. In contrast, PhDs offer each community a way to add needed personal health care services, filling identified gaps. PhDs were authorized by the state legislature in 1945, primarily to encourage the establishment of hospitals in areas where private hospital development did not appear viable. In 1992, the legislature established a subcategory of public hospital districts, a rural public hospital district. This is a public hospital district whose geographic boundaries do not include a city with a population greater than 50,000. This change authorized rural PhDs to enter into interlocal agreements with other rural PhDs to provide for healthcare needs of the people served by those districts. You can see on this chart and in the video we saw earlier that existing PhDs do not provide all of their services through hospitals, and in fact, many do not even have a hospital. In spite of their name, PhDs are not required to provide hospital services. Washington's PhDs represent a wide range in whether they operate a hospital or not, and in the complexity of or specialties in the outpatient care they give. The law permits PhDs to provide other healthcare services, including, quote, nursing home, extended care, long-term care, outpatient rehabilitative and other ambulance services, services that promote health, wellness, and prevention of illness and injuries, and other such services as are appropriate to the health needs of the population served, unquote. The examples that follow represent the range of what PhDs currently offer to Washington residents. Evergreen Health, a PhD located in King County, operates one of Washington's largest PhD hospitals, with 318 inpatient beds, including rehabilitation and hospice beds. In fact, Evergreen operates a healthcare system that offers 123 locations on its website, including many specialty and subspecialty outpatient diagnostic services and physician clinics. Evergreen Health also contracts to operate Evergreen Health Monroe, the former Monroe General Hospital owned and formerly operated by another PhD that's located in South Snohomish County. As mentioned earlier, many PhDs do not operate hospitals. The Vashon Island, Mattawa, Lopez Island, Kennewick, and Port Roberts PhDs do not operate hospitals. They meet local healthcare needs by providing outpatient care only through local physician offices and clinics. For example, the Point Roberts Health District is the only PhD located in Whatcom County and serves a population of about 1,000. It operates a clinic that offers urgent and primary care to a small part of the U.S. that's located on the southern tip of a British Columbia peninsula. Reaching it takes a 25-mile drive through Canada. And the Franklin Mesa, Douglas Waterville, Grant Royal City PhDs are some of the PhDs that provide ambulance or emergency medical response as their only current service. These rural PhDs were formed to provide ambulance or emergency medical response in an area that did not previously have this service. So what information is available about gaps that exist in our healthcare system, and how can PhDs respond? One purpose of this project is to suggest to the public that they learn about their own healthcare services and what gaps exist there. Through its law enabling PhDs, Washington offers its voters a way to influence this important part of their lives. And because these entities are governmental in nature and rely on local elected officials to govern them, the League of Women Voters Civic Education Program can provide this information to inform these efforts. We want to empower the public to achieve access to services that they have deemed are unavailable or are too far away. Some areas have a lack of basic inpatient hospital beds. There are 133 hospitals in Washington state. 40 of those, or 30% of Washington's hospitals, are operated by PhDs. But you can see on this map that some communities are still underserved. And in some communities, there's only one hospital, when having two would give local patients a choice in where they get their health care. Let's pause here for a moment for you to examine this map more closely. A few examples of services that are generally in short supply, which you might find represent gaps in service in your own community, might include mental health and substance use treatment programs, long-term care facilities, reproductive health care of all kinds, palliative care for chronic conditions, and end-of-life care, including hospice and access to medical aid in dying pursuant to Washington's Death with Dignity law. Along with service gaps, the large rural areas of Washington leave many of its residents faced with long distances and extended travel times to reach the care they need. During the COVID pandemic, the use of telemedicine to reach across these long distances advanced very rapidly. Telemedicine is being adopted by PhDs to help connect patients living in underserved areas to distant and needed care. This trend can continue to make specialty care and technology more available to small towns and rural areas. This brief video provides an example of a PhD patient at Lincoln Hospital in Davenport being linked to a specialty care that is not usually supported by small rural populations.
There may only be 10,000 people living in all of eastern Washington's Lincoln County. But through technology, residents have access to some of the best health care anywhere. Lincoln Hospital in Davenport has an innovative partnership with Providence Sacred Heart Medical Center and Children's Hospital to virtually connect patients and their primary care providers with medical specialists in Spokane.
Good afternoon, Ms. Udall. How are you today?
Just fine, thank you. I came into the hospital because of a stroke. I had no idea what it was.
She came in to our ER with significant stroke symptoms, with significant deficits.
I'd like you to stand up without using your hands. Very good. That's nice and strong. Stand up on your tiptoes. Good. Now turn towards that little bed right there and just walk towards there. I just want to see how you're walking. Very good.
We have partnered with Providence to provide telemedicine consults via the robot by hospitalists so that our primary care providers can get a consult, just make sure that we're doing everything that we can possibly be doing, keep the patient here at our local facility, keep the patient close to home, and provide the very best care that we can. And we were able to get the stroke neurologist via the robot within 15 to 20 minutes, have that consult, give her IV TPA, keep her here in-house and watch her recover over the next matter of hours and days, and now be a functioning member of our community again.
Hi, how are you? Pretty good, how you doing? I'm just mean and ornery. You're not your normal self. You bet.
Any condition that requires specialty treatment, we can access people that are on the cutting edge of that particular disease process. And I think it's given them a great deal of confidence with using our facility. And the families particularly appreciate that. Many of them from out of the area initially find it hard to believe they can get the best treatment at a small facility in a rural setting, not realizing that we have access to specialty care the way we do with telemed.
The old paradigm was you had to physically be with the patient, and that's what a hospital was all about, was aggregating all the professionals in one place and then bringing the patients to them. And that's worked for many, many years, but I think the ability now is to be able to take the professional to the patient where they're at.
I'd like you to put your arms up just like this. Okay? Now close your eyes.
We were concerned about the reaction of our patients to a robot coming in, and so we were cautious. But I have to say that as we applied it, we were really surprised at how quickly the rapport developed between the patient and the physician inside the robot.
Just to lay here in bed and talk to a fellow that's out of town, that's a specialist in his given field. It's just as if he was standing at the foot of my bed.
Having the ability to keep patients in Davenport that otherwise would have come to Spokane really is a win for that community, a win for that hospital, and keeps healthcare really robust in these rural settings.
One of the most common healthcare gaps in local care in Washington is in behavioral healthcare services. This includes both mental health care and treatment of substance use disorders. The Kaiser Family Foundation reports that since the COVID pandemic, adults reporting symptoms of anxiety and/or depressive disorder grew from 10% in 2019 to 33% in 2021. In fact, this Kaiser chart shows that suicide rates in Washington state exceed the national average. The number of behavioral health agencies which serve people with mental health conditions, substance use disorders, or both, varies widely across the state's counties. People in rural areas often have fewer options and must travel further for care. Even before the pandemic, the Washington State Health Care Authority cited a severe shortage of psychiatric hospital beds in Washington. Many general hospitals were already housing psychiatric patients in their hallways while waiting to find a bed where they might receive care.
northeastern corner of Washington state, one rural community is changing their approach to primary care to better meet the needs of patients. Newport Hospital and Health Services has joined with Pend Oreille County Counseling Services to offer residents access to mental health services right in the primary care clinic. It is a partnership that builds on the expertise of each organization, coordinates health care, and results in a healthier patient and community.
We're used to, a person comes in, falls down, we clean their wound, we put a bandage on it, and we cast them and send them on their way. Mental health is a little bit more involved with that. They have to really kind of reach out to the patient and figure out what's going on with them. And it's not just the patient themselves, it's their circumstances. We have counselors 2 hours a day, 5 days a week on site, so we can actually schedule the patients to be in clinic during the time the counselors are there.
I have patients now that are coming to see me, and then I escort them right down to mental health, and then they will sit there and work with them for a half hour, and then they come and report to me before the patient leaves.
There's a stigma in rural areas. If they park their car in front of the mental health facility, and if your neighbor passes by and sees that car there, they're going to know what you're there for. If you come to the clinic and your car's parked there, you could be in there for anything, sniffles, or it could be your mental health.
Another healthcare gap in many Washington communities is the lack of ready access to a full range of reproductive health care. This is particularly relevant to PhDs because, as government entities, they are covered by Washington's 1991 Reproductive Privacy Act. This 40-year-old law requires a PhD that provides maternity care benefits, services, or information to provide substantially equivalent abortion benefits, services, or information. An Attorney General opinion issued in 2013 reinforced the law's requirement that PhDs with birthing centers or obstetrical departments must also provide abortion care services. However, these legal provisions are only significant if they are complied with and enforced. Every Washington hospital must submit its policies about access to reproductive health services for online posting by the Washington Department of Health. Currently, the department's statewide compilation of those hospital policies show that 8 PhD hospitals do not offer abortion as part of their healthcare services, even though they do offer maternity care. A look at Washington's hospitals and their maternity care helps to frame this issue. This chart, using data from the Washington State Department of Health, shows that half of the births in Washington State take place in hospitals where religious policies prohibit their facilities, their birthing centers, outpatient clinics, and physician offices from offering the reproductive health services that many women need. These prohibitions include medical and surgical abortions, tubal ligations, and a full clinical response to ectopic pregnancies, miscarriages, and fetal abnormalities incompatible with life. In most non-secular medical facilities, the religious organization's policy prohibits certain birth control methods, any abortions, and use of death with dignity medications. It's interesting to note that although Washington State is ranked 6th most secular in the nation, about 50% of Washington live births take place in communities without a secular maternity care provider. A study published in the May 2022 Journal of the American Medical Association found that greater distance from an abortion facility was associated with increased delays in obtaining care and with inability to receive abortion care. This means that PhDs providing obstetric, reproductive, and abortion care are absolutely essential in more rural areas where distance is a big factor. Here's what one woman said about traveling to get an abortion.
Right after leaving graduate school to search for my first job, I found out I was pregnant. My IUD had failed. I'd gone home to a state that no longer permits abortions now that Roe v. Wade has been overturned. I went to the local Planned Parenthood, and since my home state is surrounded by other states that no longer permit abortions, they found a place I could go. I drove 750 miles to get to a state where I could legally have my abortion. That trip and paying for the procedure drained a lot of my savings that I'd set aside for my job search to start my career. Now that I live in Washington, I'm thankful that women here have better access than I did when I needed it.
Yet another category in which many in Washington state are experiencing unmet needs is for affordable long-term care, palliative care, and end-of-life medical support. Of these, palliative care is becoming a recognized type of specialized medical care for people living with a serious illness. This type of care is focused on providing relief from the symptoms and stress of the illness. The goal is to improve quality of life for both the patient and the family. This is distinctly different from end-of-life care. It's provided by specially trained medical personnel to give an extra layer of support based on the patient's needs and can be offered at any stage of a serious illness. A new Washington State Rural Palliative Care Initiative has been started through which many more people in rural areas can have access to this kind of care. Notice on the map where the services are provided. Nearly all are through PhDs. Another important service is hospice care, which supports terminally ill people. Individuals with only 6 months to live can receive a range of care. This service is primarily delivered at home. The map shows that a few of Washington's 40 hospice agencies are operated by PhDs.
Our focus is physical, it's psychosocial, and it's spiritual. Palliative care is delivered by an interdisciplinary team. I provide the physician aspect of care, but we work with nurses, social workers, chaplains, pharmacists, occasionally various types of therapists, to really look at the whole person and address their needs. That includes their family, their friends, their community, and especially because many palliative care patients are seriously ill and may be losing their ability to communicate their own preferences and desires. So we spend a lot of time working with medical surrogates, spouses, children, others, trying to figure out what is the next best step. Delivering high-quality palliative care in the rural setting is primarily a challenge because of staffing. Number one, they're already challenged to meet the staffing needs of just basic primary care and any subspecialty. Secondly, how do you recruit a specialized palliative care provider in any discipline into a rural setting if you don't have the volume of patients to really justify the salary and all of that? So we're seeing a lot of innovative things. In many rural communities, the palliative care champion might be a hospice social worker, it might be a hospital chaplain, often it's a nurse or a nurse practitioner, it may be a family doctor who also does hospice medical directorship. And so they're kind of finding ways to cobble together the components of the palliative care team. So much of palliative care is actually delivered in the primary care setting. Historically, medicine is thought in more of an either-or mindset. And what I mean by that is either we're pursuing hopefully curative or life-prolonging treatments, or we're doing comfort care. People would always say, oh, they're not ready for palliative care yet, meaning they're not sufficiently end of life. Now they're recognizing why wait until they're end of life to get them comfort-focused therapies. So I'm seeing many more patients now who are actively undergoing radiation therapy, chemotherapy, cardiac management. While they're receiving those treatments, they're also getting palliative care. When we first opened our clinic, we got a gentleman who had gone through head and neck cancer treatments. He was completely through his cancer therapies. he was miserable. The radiation, the surgery, the cancer itself had all left him with a pretty substantial amount of pain, nausea, malnutrition. He was still getting nutrition through a feeding tube because he couldn't swallow. And so we spent months working with him to stabilize his physical symptoms, to address a lot of his psychosocial needs. He'd become very isolated and depressed. And after about 6 months, he actually came into our clinic and said, "I don't think I needed my appointment today. I actually think I'm ready to stop coming in, and I want to open the space up in your schedule for others. But I wanted to come in and thank you because you changed my life." And, needless to say, everybody in the clinic is crying and feeling like, wow. But this is a gentleman who would never qualify for hospice at this point. He's free of his cancer. He's not end of life. He presumably has decades of life ahead. But between his physical and emotional symptom burden, he was able to come in and have a dramatic difference made.
Of course, maintaining high-quality local care and adding needed services requires reliable, sufficient funding for buildings, equipment, and staff. Thus, some key facts about financing of public hospital districts are important to share. Although the statute enabling formation of PhDs includes the authority to generate taxes for funding them, the primary source of funding for PhDs is actually the same as for other healthcare services. Most of the funding for clinics and hospitals comes from private insurance companies like Regents and Premier and Kaiser, and public insurance programs like Medicare, Medicaid, and Washington's Apple Health. This slide shows the mix of funding sources that support an average PhD that operates a hospital. Washington's urban PhDs have a typical hospital's mix of private insurance and Medicare or Medicaid, but in rural or remote areas, there are fewer, younger, employed patients who have private health insurance, which usually pays better. While those rural healthcare providers with a very high percent of Medicare and Medicaid patients are very important to the community's health, they also have greater financial challenges. Fortunately, those PhDs with critical access hospitals, which are very small hospitals with under 25 beds, are paid more generously by Medicare, protecting them financially. Importantly, 97% of PhD hospital funding comes from public and private insurance. Of the millions of dollars it takes to own and operate a hospital, the PhD taxes typically contribute only about 3% of the necessary revenue. An exception is a PhD that provides only emergency medical response services, EMS. These are funded just like other publicly supported EMS services across the state. RCW 8452 allows local governments, including PhDs, to impose a property tax of up to 50 cents per thousand assessed value for emergency medical services via a voter-approved levy. However, PhDs can issue voter-approved revenue bonds to support large capital expenditures similar to what school districts do. Examples would be for construction or for medical equipment. Also, similar to some school districts and other special districts, it may take 2 or more efforts before the required 60% of votes to approve the proposed bond issue is achieved. What can a local PhD mean for your personal tax bill? Here are a couple of typical examples. In Grays Harbor County, there are 2 PhDs. District 1 operates Summit Pacific Medical Center in Alma and a wellness center in McCleary. District 2, Harbor Regional Health in Aberdeen, operates a hospital and a medical group. One has a property tax levy of 47 cents per $1,000 assessed valuation. The other has a property tax levy of 53 cents per $1,000 assessed valuation. The resulting impact on the residents' property tax bills is shown here. For very little investment, the public gets an important benefit. Here's another example from Clallam County. Clallam County has 2 PhDs, and this bill reflects the one in which the taxpayer's residence is located. You can see that the hospital district tax costs a little less than the emergency medical service tax and a little more than the local library system tax. These are some resources for additional information about PhDs. In conclusion, there are gaps in healthcare services across Washington state, particularly in rural areas. These include access to certain services such as behavioral health services, a full range of reproductive services, palliative care, hospice, and access to the provisions of Washington's Death with Dignity law. A PhD can be one alternative to consider when identifying and addressing these needs in your own community. Watch for the next 2 parts of our project: a slide presentation about how the public can work with an existing PhD and its Board of Commissioners, and a toolbox with information about how new PhDs are formed. We hope this webinar has helped you better understand public hospital districts. Thank you for watching.